Welcome everyone to another special episode of Arthritis Consumer Experts, hashtag CRArthritis. I'm very pleased today to be joined by Dr. Whitney Hung, a graduate of the medical school and internal medicine residency program at the University of Alberta, and currently a rheumatology resident, and an old friend of ours, Dr. Stephen Katz, director and professor, Division of Rheumatology, University of Alberta. Doctors Hung and Katz, welcome to the show.
Thank you.
Thank you.
We're going to focus today on a poster you're presenting that's titled Uncovering Rheumatologic Disease in the Northwest Territories, First Comprehensive Baseline Study and Comparative Insights. As many of our viewers and audience know, we've been involved, ACE, along with some other organizations like the Canadian Rheumatology Association and Arthritis Society Canada, about the models of care for arthritis patients in Northwest Territories. And we're really excited to be talking to you today about your study. And one of the things the study highlights is the long wait times and high rates of patient no-shows or cancellations in the Northwest Territories. What do both of you what have you determined are some of the biggest barriers preventing patients from accessing timely arthritis care, and what can be done to improve this?
So I think right now the number one issue is lack of rheumatology care in Northwest Territories. As you know, over the last couple of years, we've been seeing these patients now in Edmonton instead of what our longer term program was always seeing them in the Northwest Territories. The patients needing to travel down to Edmonton, I think, creates a lot of barriers. Certainly, as you saw in our study, we were able to show that no-show rates are much higher for that population compared to what we usually see, essentially double from what we would see for patients that are from Edmonton or from central or northern Alberta. So patients are not able to access care, even if they may want to be able to come down, but there's other barriers in terms of just travel to get to Edmonton. From Yellowknife, it's a 3-hour flight, and assuming you don't live in Yellowknife, that's an additional flight, which creates a lot of barriers. And then staying in Edmonton for at least a couple of nights, being away from work, being away from family, those aren't easy things to do. Whereas if we're able to provide that care in Yellowknife, certainly still not necessarily easy if you're not in Yellowknife itself, but is a lot better, I think, in that respect. So ideally, I mean, being able to tear down that barrier and go back to a system like we had before likely would help solve a lot of that. Certainly, you know, having more rheumatologists itself in Yellowknife or Northwest Territories, or access to, as you talked about at the beginning, a model of care with allied health professionals working alongside with rheumatologists would really expand the total capacity of care for that population as well, because likely one rheumatologist on their own is also insufficient.
And in terms of the work that I referenced earlier that ACE has co-led with the CRA and Arthritis Society Canada, we particularly have been advocating for the people affected who are living with inflammatory arthritis and disabling diseases like rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. As our audience is well aware, these are serious diseases that, when untreated or undertreated, can deeply, deeply impact a person's life. And these are people who are dependent on a timely diagnosis and access to treatments, as I'm sure you're going to talk about. And the majority of people with these diseases can live a full life with minimal disability or long-term consequences if they get access to that treatment and timely diagnosis. But without it, we've referenced, of course, that almost half of these patients can go on to develop some form of disability within 10 years and require expensive joint replacement surgery, loss of employment, and have a dramatic increased risk for other comorbidities. So I just wanted to make sure that we were all clear from an audience point of view, who are the ones that are really vulnerable here. So compared to Edmonton, your study found a higher prevalence of psoriatic arthritis and ankylosing spondylitis, but a lower rate of vasculitis in the Northwest Territory population. What might explain these differences, which we found interesting, and what are the implications for patient care?
Yeah, so I'm not fully sure what that data means. I think that in terms of the increased prevalence of psoriatic arthritis and ankylosing spondylitis, there may be some genetic component to it, given that the majority of our cohort was of Indigenous descent. That being said, I think we're in the very early stages of figuring out what this means. But yeah, certainly there could be a genetic component to it, similarly to what we've seen in things like rheumatoid arthritis in other populations. In terms of the lower rate of vasculitis, it's hard to say if it's truly a lower prevalence. I think that may play a role given that we didn't actually make any new diagnoses of vasculitis in this cohort, compared to 9% of patients in that same year in the Edmonton cohort. But I think another factor that plays in is that perhaps we're catching these patients later in their disease course, and maybe these patients are only being seen when they're sick enough to need hospitalization and then transfer to Edmonton, in which case they would have bypassed this entire referral process, and we would have missed them that way. And so again, I think this may highlight another barrier to care when it comes to getting access in a timely manner.
I'm going to ask Dr. Katz, just to underline again the implications that this transfer of care has had on arthritis patients in Northwest Territories. Dr. Katz, how many people approximately now have established care in Edmonton, and how many have either canceled their appointments or have not been able to travel to make these appointments? What kind of numbers are we looking at?
So initially, there was just over 400 patients who had their care transferred from in territory to down to Edmonton. And then since then, it's about just even over the last year, so say since last April to about now, it's close to 150 additional new referrals that we're seeing for care. And we anticipate that rate is pretty steady state. So we're talking about 400 initially, and now every year an additional 100, 150 folks who are seeking care here.
Dr. Hung, you mentioned the Indigenous population, patient population. What a lot of our viewers and audience members know from the work that ACE has done is that Indigenous patients may be disproportionately affected by these access barriers. What kind of steps are you two proposing or advocating for that should be taken to ensure more equitable care for these populations?
So I think our study again is very preliminary, and it kind of gives us just an initial glimpse of what we may be dealing with in this population, what might be more prevalent, and what we should be looking out for. I think knowing what's maybe more prevalent does help prime healthcare workers and to help prime the population to look for certain symptoms and signs that might help with earlier identification of disease. I don't think that, the fact that females and the Indigenous population are predominantly affected is necessarily new information. But I think seeing that information again does help remind us that we should be looking for these things in this particular population. In terms of specific steps, I think it's difficult to have very like directed strategic steps made at this point, because we don't know kind of the nitty gritty of it right now, or maybe Dr. Katz has a little bit more insight into that.
Hmm.
Um, but I think it's difficult to have strategies without having concrete data to kind of back that up. And so I think now we have a bit of a jumping off point where we can look into additional information and things like, what is their disease activity like? Or what kind of medications are these patients needing? For the most part, are they needing a lot of biologic medications? Because I think understanding these smaller details will help us um, get more direction in terms of what smaller steps should be made in these specific areas to help patient care as a whole.
I would agree with that. And I think, again, not specific necessarily to NWT, but overall, I mean, rheumatic disease really is an Indigenous health issue. It is a women's health issue. And I think we really need to promote that stronger because there's so much of it's just arthritis, and rheumatology's, even the word is very poorly misunderstood. And I think we're much less face time in terms of focus in the healthcare system because of that misunderstanding. But I think folks understand and prioritize, as they should, Indigenous health and women's health, and really that is a big proportion of what we do in rheumatology.
And we can't express our support for your work, and we're so thankful for the research that you're doing in this area. Encouraged to hear that with this baseline of understanding, you're going to be pursuing uh, further avenues of research, which is going to really be important to make the case that um, the patient population, in particular the women and Indigenous people living with arthritis in Northwest Territories, uh, deserve world-class care, in territory care if possible. That's going to be cost effective for the government to deliver. Before we end off, I would like to ask Dr. Katz, um, we know that you have been in discussions with the NWT Health and Social Services Authority. Can you give us an update on where you are at in terms of coming up with longer term solutions that will benefit these vulnerable populations?
Yeah, I mean, certainly we have a plan. We have clearly outlined what we think can make this work with both NWT as well as the province of Alberta. I think we have to keep in mind that with all these patients coming down to Alberta, it's affecting access to care for Albertans as well. So certainly both governments are aware of our proposals and why this work is important. And now we're really just waiting for one of our partners to step up and to be able to do that work with them.
Well, thanks to both of you for joining us today. I will be looking for you at the poster session, providing whatever support I can, because once again, we're behind you all the way. And congratulations on the study.
Thank you.
Thank you.
And thanks to everyone watching and listening. We hope that you can join us again for another episode of hashtag CR Arthritis. Goodbye for now.